Okay, I'm going to talk about ACLS-Tachycardia. So this is a patient who has symptomatic rapid heart rate and greater than 120 beats per minute. And you first thing you do is you assess the patient. So you do a focus exam, do vitals, assess for mitral stenosis, pulmonary edema, murmurs. Are they warm or cold? Are their pupils dilated or constricted? And any other symptoms. You review their most recent ECG, any telemetry, labs, meds, events. You obtain a 12-lead ECG, get the defibrillator and pads ready to go. You get IV access, draw blood for BMP, magnesium, lactate, troponin. If suspecting ischemia, you monitor the blood pressure frequently, and then for O2, you supplement to greater than 94% and maintain their airway. Make sure it's open. And then, is the patient unstable? So do they have any signs of hypotension, shock, altered mental status, ischemic chest discomfort, angina, or acute heart failure, pulmonary edema? If so, then you want to go straight to shocking. Prior to shocking, you want to give analgesia to help them relax and not feel the pain. So you give 1 to 2 milligrams Dilaudid and sedation, 2 milligrams lorazepam, and you do either synchronized cardioversion or defibrillation. First of all, what does narrow mean? So narrow is less than 120 millisecond QRS. That's 3 small boxes. If it's less than that, it's a narrow rhythm. And is the rhythm regular? So is there a regular rate between the QRSs, or the QRSs, the width increases and decreases? So that determines if it's regular or irregular. So if it's narrow and regular, your differential diagnosis for that is either Wolff-Parkinson-White, most commonly sinus tachycardia, atrial tachycardia, or atrial flutter. And for this one, you can try adenosine prior to doing synchronized cardioversion. But so if you do decide to do synchronized cardioversion, the dose is 50 to 100 jolts. So then we're going to talk about narrow and irregular rhythms. So narrow and irregular rhythms, the differential diagnosis is most commonly atrial flutter with rapid ventricular rate. You also have monomorphic atrial tachycardia, atrial flutter, and other rhythms. And so for this one, if they're symptomatic, you want to give synchronized cardioversion. You do 120 to 200 jolts. And then the next one is wide and regular. So the differential diagnosis for this is monomorphic ventricular tachycardia, SVT with aberrant conduction, and others. And if they're unstable, you want to do synchronized cardioversion. You do 100 jolts. Then wide and irregular, these ones typically are for atrial fibrillation and atrial flutter, or you have torsades or other ventricular fibrillation. So for this one, you want to go ahead and defibrillate them and give 120 to 200 jolts. Okay, so let's say the patient is not unstable. So in this case, you want to try medications first. The first thing you do for narrow and regular is they're stable, you do vagal maneuvers. So vagal maneuvers, the most effective one is having them blow into a 10 cc syringe, and this is 43% effective in breaking SVT. And the other ones you could do is dunk them into a bucket of ice or doing a carotid massage. These are less effective, but you can use them if the syringe thing doesn't work. So let's say the vagal maneuvers are ineffective at breaking the tachycardia. Next thing you could do is adenosine. So adenosine, the dosing for that is 6 milligrams rapid IV push, followed by normal saline flush, plus the arm raise, and then you could repeat 1 time with double the dose. Make sure if you're using a central line, you use half the dose. But let's say adenosine doesn't work, then you go to IV beta blockers or diltiazem. Diltiazem you don't want to use in ischemic heart disease, so any history of heart failure with a reduced ejection fraction. So beta blocker dose is metoprolol 2.5 milligrams over 2 minutes. You can repeat every 5 minutes for the max dose of 15 milligrams. Another thing is you can use amiodarone or procainamide if you're suspecting Wolff-Parkinson-White. But let's talk about narrow and irregular rhythms. So these are the atrial flutter with atrial fibrillation with rapid ventricular rate, or atrial flutter, or blah blah blah. So first thing you do is IV beta blockers or diltiazem, and I've already mentioned this. So if that persists, then you do amiodarone, and you can also try digoxin. And let's talk about wide and regular. So wide and regular, this is your monomorphic ventricular tachycardia or SVT with aberrant conduction. And this one you could do amiodarone, which is okay for ventricular tachycardia or SVT. If the ejection fraction is greater than 40%, you give lidocaine and sotalol and procainamide and metoprolol. You can choose one of them. Don't give all of them at the same time. And an ejection fraction less than 40%, you can give lidocaine. And if the SVT and whatever, I'm not going to talk about that. Forget about that. So then you have wide and irregular rhythms. You have lidocaine plus 2 grams magnesium. And if you suspect torsades, you give another 2 to 4 grams magnesium. Otherwise, you can do amiodarone plus procainamide. But that's basically the gist of ACLS tachycardia.